Hi all, welcome to another video. So in this video, I am going to explain in detail about the anatomy of ankle joint. So coming to the introduction, the ankle joint is a strong weight-bearing joint of the lower limbs. So the ankle joint is otherwise known as talocrural joint. And the ankle joint is important during ambulation because it adapts to the surface of which one walks. So coming to the type and variety, so the ankle joint, otherwise known as talocrural joint, it is a synovial joint, synovial type of hinge variety. So that means uniaxial movement is possible. Mainly your dorsiflexion, plantar flexion, inversion, eversion movements are possible in this ankle joint. So coming to the articular surfaces. So as you know, articular surface, there are two articular surfaces in order to form a joint. That is your proximal articular surface and your distal articular surface. The proximal articular surface is formed by three different structures. That is your lower end of your tibia, including its medial malleolus. Next is your lateral malleolus of your fibula. And the third structure is your inferior transverse tibiofibular ligaments. So these three together forms a deep socket known as tibiofibular socket. So this socket is known as proximal aspect socket is known as tibiofibular socket, otherwise known as tibiofibular mortis. So this tibiofibular mortis, in other words, it is known as your ankle mortis. So this is the proximal articular surface, and the distal articular surface is formed by the body of the talus. So this is the body of the talus, so which is a wedge shape, and it also presents three articular surfaces for the three different proximal articulations. So this is in brief about the articular surfaces. That is your proximal articular surface and your distal proximal articular surface and your distal articular surface. So next one, so already I discussed, this is the proximal articular surface formed by the three different facets. That is your lower end of tibia, including its medial malleolus. Next is your lateral malleolus of your fibula and the inferior transverse tibiofibular ligament. So this will be forming a deep socket that is known as your tibiofibular socket, otherwise known as tibiofibular mortis or ankle mortis. So coming to the distal articular surface, so the distal articular surface of the ankle joint is formed by articular facets of the superior or upper, medial and lateral aspect of the body of talus. So the distal articular surface is formed by your body of talus, that is your three different facets. So first facet is your superior facet. So superior facet, otherwise known as trochlear surface. Superior surface is otherwise known as your trochlear surface. So this is in wider anteriorly, and next is your medial comma shaped articular surface. So this is your medial comma articular surface, and next third facet is your triangular articular surface. So this will be triangular articular surface will be articulating with the medial aspect of your lateral malleolus, and the comma shaped facet will be articulating with the lateral aspect of your medial malleolus, and the superior surface or trochlear surface that will be articulating with the inferior aspect of the lower end of tibia. So this is all about the proximal and distal articular surface. So coming to the stability of the ankle joint, the trochlear surface on the superior aspect of the body of the talus is wider in the front or in the anterior aspect than the posterior aspect. So during dorsiflexion, the anterior wider part of the trochlea moves posteriorly and fits properly into the tibiofibular mortis. Hence, the joint is stable. So the joint is more stable in the dorsiflexion movement. So in other words, dorsiflexion movement is the more stable position of your ankle joint. And next movement, that is your during plantar flexion, the narrower posterior part of the trochlea does not fit properly in the tibiofibular mortis. Hence, the joint is unstable during plantar flexion. In other words, plantar flexion is the unstable position of your ankle joint. So this is the diagram. So during dorsiflexion and during plantar flexion. So during dorsiflexion, so it is the most stable position of your ankle joint, and during plantar flexion, it is the unstable position of your ankle joint. So because of the proper fitting of the mortis within the posterior socket. So that's why, hence, dorsiflexion is the more stable and plantar flexion is more or less stable in the ankle joint movement. So coming to the factors maintaining the stability of the ankle joint. So there are some factors that maintains the stability of the ankle joint. So which includes close interlocking of its articular surfaces, strong medial and lateral collateral ligaments, deepening of the tibiofibular socket posteriorly by the inferior transverse tibiofibular ligament, and tendons 4 in front and 5 in the posterior aspect crossing the ankle joint and the other ligaments of these joints. So mainly your capsule and other ligaments apart from your medial and lateral collateral ligaments. So these are the factors that maintains the stability of the ankle joint. So ankle joint is one of the most stable joint in the body. So next is about the ligaments. The most important ligaments of the ankle joint are your capsular ligament, medial collateral ligament, and your lateral collateral ligaments. So medial collateral ligament is otherwise known as your deltoid ligament, and lateral collateral ligament also have some different fibers which will be explained in the upcoming slides. So first is your fibrous capsules. So it surrounds the joint completely. It is attached to the articular margins of joints all around with 2 exceptions. So postero-superiorly it is attached to the inferior transverse tibiofibular ligament, and antero-inferiorly it is attached to the dorsum of neck of talus at some distance from the trochlear surface. So the capsule is thin in front and behind to allow the hinge movements. That means the capsule is thin in the anterior and posterior aspects, and it is thick on the both lateral aspects or both the sides where it blends with the other collateral ligaments, that is including your medial and lateral collateral ligaments. So in the either sides it is thick and blend with the collateral ligaments, and it is thin in front and behind to allow the movements, that is your dorsiflexion and plantar flexion. And the synovial membranes lines the inner surface of the joint capsule but ceases at the periphery of the articular cartilages. A small synovial process extends upward into the inferior tibiofibular syndesmosis. So this is all about the fibrous capsule or capsular ligament. So next one is the one of the collateral ligament, that is your medial collateral ligament, otherwise known as your deltoid ligaments. So the deltoid ligament is a very strong triangular ligament on the medial side of the ankle. So it is divided into 2 parts mainly, that is your superficial part and deep part. So above both the parts have a common attachment to the apex and margins of the medial malleolus. Below, the attachment of superficial and deep parts differs as under. So the superficial part, it has 3 different fibers, or divided into 3 different parts. So that is your anterior, otherwise known as tibio-navicular fibers. So these tibio-navicular fibers, so you can see here, this is the tibio-navicular fibers. So these are attached to the tuberosity of the navicular bone and the medial margin of your spring ligaments. So the anterior, in otherwise known as tibio-navicular fibers of the superficial part of the deltoid ligament, are attached to the tuberosity of the navicular bone and the medial margin of the spring ligament. So next fiber is your middle fiber, otherwise known as tibiocalcanean fiber. So these are attached to the whole length of the substanculum tali. So this is attaching to the whole length of the substanculum tali. So next part is your third part, that is your posterior fiber, or the otherwise known as posterior tibiotala fibers. So they are attached to the medial tubercle and the adjoining part of the medial surface of the talus. So they are attached to the medial tubercle and the adjoining part of the medial surface of the talus. And coming to the deeper part, so the deeper anterior tibiofibula. So this is the deeper part or the deep fiber. It is known as your anterior tibiotalar. This is attached to the anterior part of the medial surface of the talus. So it has 2 parts, that is your superficial part and deep part. Superficial part is again divided into 3 parts, that is your anterior tibio-navicular fibers, middle tibiocalcanean fibers, and posterior tibiotalar fibers. So coming to the lateral ligament, so that is your lateral collateral ligament. So this also consists of 3 parts, that is your anterior talofibular ligament, posterior talofibular ligament, and the calcaneofibular ligaments. So coming to the anterior talofibular ligament, so this is a weak flat band which extends forward and medially, so which is extending forward and medially from the anterior margin of the lateral malleolus to the neck of talus, just in front of the fibula facet, So next ligament is your posterior talofibular ligament. So this is a strong band which extends backward and medially from the posterior margin of the lateral malleolus to the posterior tubercle of the talus. So this is the posterior tubercle of talus. So next ligament, that is your third ligament, that is known as your calcaneofibular ligament. So this is a long rounded cord-like structure, so which runs downward and backward, so inferiorly and posteriorly from the notch of the lower border of the lateral malleolus, from the lateral malleolus to the tubercle on the lateral surface of the calcaneum, to the calcaneal tubercle. So this is the three different ligaments and their attachments. So lateral collateral ligament. Coming to the relations of the angle joints, anteriorly from medial to lateral side, the angle joint is related to the following structures. So that includes your tibialis from medial to lateral. It includes your tibialis anterior muscle, extensor hallucis longus muscle, anterior tibial artery, deep peroneal nerve, extensor digitorum longus muscle, and the peroneus tertius. So anteriorly, it is surrounded by four muscles and your anterior tibial artery and your deep peroneal nerve. And posteriorly, from medial to lateral side, so it is surrounded by your tibialis posterior muscle, flexor digitorum longus, posterior tibial artery, posterior tibial nerve, flexor hallucis longus. So the anterior relation from medial to lateral side of the angle joint is related to the following structures, which I already discussed. And this includes your tibialis anterior, extensor hallucis longus, anterior tibial artery, deep peroneal nerve, extensor digitorum longus, and peroneus tertius. So this can be remembered by the mnemonics. The Himalayans are not dry plateaus. So the T for the tibialis anterior, H for your extensor hallucis, and A for your artery, that is your anterior tibial artery, N for your nerve, that is your deep peroneal nerve, D for your digitorum, extensor digitorum longus, P for your peroneus, so peroneus tertius. So this is the anterior relations of your angle joint, and the posterior relations of that is the structure that is crossing the angle joint in the posterior aspect includes your tibialis posterior, flexor digitorum longus, posterior tibial artery, posterior tibial nerve, and flexor hallucis longus. So this can be remembered by the mnemonics. The doctors are not here. So T for your tibialis posterior, D for your digitorum longus, that is your flexor digitorum longus, and A for your artery, that is your posterior tibial artery, N for your nerve, that is your posterior tibial nerve, and H, that is your flexor hallucis longus. So this is the anterior and posterior relations of your angle joint. So coming to the blood supply, that is your arterial supply. So it is supplied by the malleolar branches of your anterior tibial, posterior tibial, and peroneal arteries. So the angle joint is supplied by your anterior tibial artery, posterior tibial artery, and your peroneal arteries. Coming to the nerve supply or nerve supply, so it is supplied by the branches of your deep peroneal and tibial nerves. So segmental innervations is your L4, L5, S1, S2 spinal segments. Coming to the movements or motions possible in the angle joint, it includes your dorsiflexion and plantar flexions. So the dorsiflexion, the principal muscles include your tibialis anterior, and the accessory muscles include your extensor digitorum longus, extensor hallucis longus, and peroneus tertius. So these are the muscle which is located in the anterior aspect of your or anterior compartment of your joint. So next movement is your plantar flexion. So the main muscle, the principal muscle includes your gastrocnemius and soleus, and the accessory muscle include your plantaris, tibialis posterior, flexor hallucis longus, and flexor digitorum longus. So these are the movements that is possible in the angle joint, dorsiflexion and plantar flexion. So coming to the dorsiflexion, we will be explaining in detail. So in dorsiflexion, the forefoot is raised and the angle between the front of the leg and dorsum of the foot is diminished. So in this movement, the wider anterior part of the trochlea is forced posteriorly between the malleoli, and it is a close packed position of the angle joint with maximum concurrence of the articular surface and the tension of the ligaments. The angle joint is the most stable in dorsiflexion movement, and the range of motion is 20 degree for your dorsiflexion, and this dorsiflexion is controlled by your L4 and L5 spinal segments. So this is the dorsiflexion movement, and this movement is the most stable position of your angle joint. So coming to the next movement, that is your plantar flexion. So in this plantar flexion, the forefoot is depressed. So the forefoot is depressed in this plantar flexion motion, and the angle between the leg and foot is increased. So in this position, the tibiofibular socket encloses the narrower posterior part of the trochlear surface of talus, and some joint space is available between the tibiofibular angle mortis and the narrower portion of your trochlea or narrower posterior part of your trochlea. So it is a loose pack position of the ankle joint, and this is the most unstable position of the ankle joint. So the range of motion will be 45 degree, and in the plantar flexion, this was innervated by the S1 and S2 spinal segments. So this is all about your movement, that is your motions that is happening in your ankle joint, that includes your dorsiflexion and plantar flexion. So this is the summary of the movement. So this is the normal or anatomical position, and this is the dorsiflexion movement, and this is the plantar flexion movement. So coming to the clinical correlation, the first correlation is your ankle sprain. So what is ankle sprain? So ankle sprain is the excessive stretching or tearing of the ligaments of your ankle. So that is known as your ankle sprain, and it is usually caused by fall from height or the ankle twist. So both your lateral collateral ligament and your medial collateral ligaments are injured. So there are two types of injuries occurring during these ankle sprains, either your injury to your medial collateral ligament or injury to your lateral collateral ligaments. So the lateral collateral ligament, so coming to the first injury, that is your lateral collateral ligament injury. So these are injured when the foot is in plantar flexion. So that is the plantar flexed foot is excessively inverted. So lateral collateral ligament injury occurs as a result of plantar flexion plus inversion. So this is known as your inversion sprains. There are two sprains that is occurring in the ankle joint. That is your inversion sprain and eversion sprain. So inversion sprain is the type of sprain that occurs as a result of injury to your lateral collateral ligament. So your plantar flexed foot with your inversion motion will lead to inversion sprain. And next sprain is your eversion sprain. So eversion sprain occurs as a result of injury to your deltoid ligament, otherwise known as your medial collateral ligament. So same motion only, plantar flexed foot but eversion. So plantar flexed foot plus eversion may lead to medial collateral ligament injury, that is your eversion sprain, and plantar flexed foot plus inversion may lead to your lateral collateral ligament injury, that is your inversion sprain. So but usually in the ankle sprain, lateral collateral ligament is the most common occurring sprain, and deltoid ligament, usually there will not be any particular tear. So deltoid ligament are not prone to tear comparing to your lateral collateral ligament because of the pull of these ligaments. So because of this pull of this ligament, the medial malleolus will be having some eversion fracture rather than the medial collateral ligament tear. There will be a happening of eversion fracture of the medial malleolus. So in essence, we can say that inversion sprains are more common than eversion sprains. So coming to the second clinical correlation, that includes a dislocation of the ankle. The dislocation of the ankle joints are very rare because it is a very stable joint due to the tibiofibular mortise or ankle mortise. However, whenever dislocation occurs, it is always accompanied by the fracture of any of the malleoli. So ankle joint is very less dislocated joint in the body. Sometimes it is dislocation is occurring means it may accompanied by the fracture of either your medial or lateral malleolus or your posterior tibia, that is your trimalleolar. So coming to the third clinical correlation, that is your POTS fracture. So the POTS fracture is your fracture dislocation of the ankle joint. So it occurs when the foot is caught in a rapid fall and everted forcibly. So this is the POTS fracture. So POTS fracture occurs as a result of fracture dislocation of your ankle joint. So it is a term that is used to describe a bimalleolar. So both your medial and lateral malleolar, or it is otherwise known as trimalleolar. So trimalleolar means your medial, lateral malleoli and your distal tibia will be getting fractured. So these are the three structures that are going to happen in the POTS fracture. So these are three events that is going to happen. So in this condition, the following sequence of events can take place. First one is your oblique fracture of the lateral malleolus due to the internal rotation of tibia. So oblique or a spiral fracture of your lateral malleolus of your fibula, and next is your avulsion fracture or transverse fracture of your medial malleolus due to the pull of this strong deltoid ligament or the medial collateral ligament, and the fracture, and the third event is your fracture of the posterior margin of your lower end of the tibia. That is your third malleolar. This is the first malleolar, second, and the third malleolar. This is all together. This is known as trimalleolar. These stages are also termed as first, second, and third degree of Pott's fracture, respectively. So the third degree of this Pott's fracture is also known as trimalleolar fracture. So Pott's fracture can occur as a bimalleolar fracture, that is both your lateral and medial malleolar getting fractured, or it may occur as a trimalleolar fracture, that is your medial, lateral malleolars and the distal tibial fractures. So all these three fractures is known as trimalleolar fracture, that is your Pott's fracture. So coming to the optimum position of your angle, the optimum position of the angle is one in which the angle joint is in slight plantar flexion. The knowledge of this position is essential for applying plaster cast in the angle region. So by this, I'm concluding this anatomy of the angle joint. Hope you understand this topic. Thank you for watching this video. Please do share and subscribe this video to your physio friends and fraternity. Thank you.